lucky to have a bunch of guest speakers visiting us when it rains, of course. And today, you know, save the best for last, right? This is Brian Jackson, and he is visiting actually from London, living in London right now. But his permanent position is at the University of Utah and at ARUP, which is a reference lab clinic, which he'll tell you a bit about, I think. And Brian and I have known each other for quite a long time. We were both students of the same program, although we weren't in the program together. And he's been in different positions around the world. And when I interviewed for the chair position at the University of Utah, I guess 9 years ago, or almost 10 years ago, I met with him, and he really inspired me about the potential for collaboration with industry and how academics and industry needing to work together is, you know, that's one of the big gaps in the transformation of healthcare, is that they're not working together. And so that really got me thinking about that from that point forward, and have been working towards that goal, you know, with a teeny bit of success. We still have that goal, and we are working towards it, and it's going to take time.
Takes time.
Yes. But he's also just a really thoughtful person, and passionate about the ethics of what we do and the impact of what we do and making a difference. So welcome, Brian. We're really looking forward to your talk.
Thank you. So my first visual memory of Wendy was the basement of LDS Hospital. I was a research assistant in college when he was working on her PhD, and I just have a visual memory of you and a very colorful iMac. So that's the era.
It was green.
We're old.
The first iMacs, they were plastic and
they were
green.
gorgeous, but I was very jealous because I didn't have one. Yeah. So my background, at the University of Utah, I'm in the Department of Pathology, and 40 years ago they launched a company. Basically to do laboratory testing. So most medical laboratory testing, you know, is done by, you know, nonprofit corporations, or in some cases for-profit corporations. And my academic department, many years before I got there, took a look at that and said, well, we know how to do that. Why can't we start a business? And they had to, there was a big cultural barrier to get past, to convince people at the university that number one, they could do it, and number two, that it was actually in keeping with their academic mission. But eventually they were able to pull it off. And it is, you know, one of the largest testing laboratories in the United States. It's technically a nonprofit, but what that means is that all of the profits flow back into the university to support the university, and it supports a lot of faculty, and it's just a great model. So through my career, my past 20 years, I've had this really strong interest to think, what can sort of academics and medicine and industry all learn from each other, and how could we, you know, get the best of all of them, because there are too many silos here. And there's a lot of valuable stuff in industry that academics tends to, you know, brush off or poo-poo or say, well, that's just dollars, without really taking it intellectually seriously. But I think it happens on the other side as well. So that's sort of where my interests have been, and it led me into thinking about these issues of ethics and how do we engage in medicine better with society in a way that's healthier. And AI ethics seems to be a hot topic now, so that's what I was going to talk about today. So I wanted to start off with a story that it is admittedly not a healthcare story, but I think it illustrates nicely the issues that we run into in healthcare, and that we're going to be running into increasingly as AI becomes bigger in healthcare. So with that disclaimer, so the story here is in January of 2020, right before COVID, you know, disrupted every place outside of China. The man in the picture is named Robert Williams. He lives in Detroit, Michigan, which is a large city in the sort of the north central US. And one day in January of 2020, he drove home from his work in downtown Detroit into his home in the suburbs. And when he pulled in the driveway, there was a police car there, and two police officers got out and proceeded to arrest him. and he had no idea why. They wouldn't tell him. His wife, his 2 daughters that are in the picture were watching this. Very traumatic, very upsetting. They wouldn't say anything, didn't know what was going on. He was just very confused. It was a number of hours later at the police station that he finally understood what, sort of what was going on here. There had been a robbery that day at an expensive store in Detroit that sells watches and jewelry. And the store had a surveillance camera and had caught video of the burglar, the perpetrator, the robber. At which point the policeman pulled out a print from the video that had the face of the person robbing the store, held it up next to Mr. Williams' face, and it was obvious to everyone in the room that it looked nothing like him. The only thing they had in common was they were both black. But other than that, the facial features were completely different. The investigators, it was a little bit awkward. They weren't sure what to do. They ended the interview. They sent him back to his cell. They should have just let him go completely. But of course, police aren't going to do that. Because they think, well, maybe he really did it and there's a technical problem here. Even though that was literally the only piece of evidence that they had. They had nothing else linking him to the crime other than this faulty picture. So he had to put up, I think like $10,000 or $1,000 bond for a $10,000 bail to get out to go home. He had to take a day off work a few weeks later to go down to the court to stand in front of a judge and face the charges because they hadn't dropped them. And it wasn't until then that the prosecutor realized they had zero evidence because the picture was obviously not a match and let him go. But this was not a positive thing. So what happened here? Who was at fault? Well, so the match was made against the state driver's license database. And it was done by software produced by this company. I copied and pasted from their website. You can tell this is not a big company. They need a graphics department, among other things. This is a little boutique software company that just sells, database services to police departments in the US. And someone at this company thought it would be a good idea. They sell basically databases for paperwork management, but also management of the do you call them mugshots in Australia? The arrest photos that they take of the suspect. So management of the image database for that. And so they thought, well, we've got all these images. I bet policemen would like to do automatic facial recognition on this. So they found some third-party algorithm to do facial recognition, and they just packaged it in and started selling it to police departments. Didn't tell anyone, didn't do any validation. Honestly, just looking at the quality of the graphics here, you would guess they probably don't have any machine learning experts on staff. This is probably just a little company that sort of hacks stuff together, is my best guess. Whoops. I just lost the feed here because I bumped my computer.
Someone write down the MAC number so we can hack this.
That's all right.
Probably one of these keys. Okay, escape. And I'm trying to try again. There we go. Okay, we're back. Okay. So the impact, I mean, this is really upsetting, and he's really embarrassed. And yes, we're back.
Okay, that's
Yes,
what you're on your computer.
That was the slide.
Okay.
So he's embarrassed, he's upset, his family's traumatized, and being Black in America sort of makes you vulnerable to having to be extra careful around the police. And now his arrest photo is in their database, which makes him susceptible to being misidentified in the future in a variety of different ways. His fingerprints are now in the system, which makes him vulnerable to being sort of misidentified if they get a partial fingerprint match. So he's feeling very vulnerable here. So even though he didn't go to prison, there was still a significant social negative impact here. It wasn't actually until the New York Times did an article on this that the prosecuting office was embarrassed into expunging all of those records. So they did eventually erase them all, but it wasn't until a reporter kicked in. They didn't, the prosecuting office didn't do the right thing until they were pressured to. But where were the ethical lapses in this? So number one, a vendor selling facial recognition software for a high stakes application, namely criminal justice, has no business doing this if they don't understand the software that they're selling. And they have no business, and if they don't understand the software they're selling, they have an ethical obligation, knowing how it's going to get used, to bring in that expertise one way or another and make sure that this is properly validated. But they didn't do that. How about the police department? So I don't have numbers here, but if I had to guess how many computer science PhDs were on staff at the Detroit Police Department, I'm going to guess that it was probably this many, and probably the same that would maybe be on staff at the Melbourne Police Department. I don't know. But you don't think of police departments as having deep expertise into some of these technology issues. So what business do they have implementing something that they don't understand, they don't know how to validate, they don't understand the risks of it? And I don't even blame the police department necessarily, but the attorneys that they worked with should have known better, should have realized this was a setup for problems, and they didn't. So it was a major ethical lapse. And fortunately, they were sufficiently embarrassed by the police coverage or the newspaper coverage that they reversed course. They stopped, at least they promised that they weren't going to use the software anymore. I don't know if that's true or not. Question.
How much did the software cost? Like how much did taxpayers
That I
have to
don't
run?
know.
Okay,
That's a good question, actually.
that's another crime.
I'll have to look at the article and see if they knew that, but probably a lot. If I had to guess. But I don't know. Okay, onto a medical example, and you'll see that there's some of the same patterns here. And let me know if anyone's seen this story before. It made a lot of news in the U.S. There's a company in the U.S. called United Healthcare. So in the U.S., outside of people over the age of 65, most healthcare is paid for by private insurance companies that are paid through employers. And the largest, by quite a long shot, is United Health, massive company. A number of years ago, United Health made what I think was a smart strategic move from them, and they started growing their data science group. And the core of the data science group was a company that spun off of the University of Utah informatics department named Ingenix. I don't know if you know the history of Ingenix, but it was one of Reed's buddies and back in the 70s that started this healthcare data science group that eventually turned into a big division of United Healthcare. So there was this headline that New York state regulators were investigating them for racial bias because of software they were selling. So what was going on? Well, basically what the software was population health software used by hospitals. You plug in several years worth of billing data that basically for all of the patients you're taking care of. And based on that, it estimates how expensive each of those patients is likely to be in the next year. So it's a simple idea. You're just taking historical healthcare expenses and projecting the most likely expenses for the next year. Why would a hospital want to do this? Well, the scenario where a hospital in the US would want to do this is some hospitals in the US take on essentially insurance contracts for a population of patients. So they'll get per member. This is not the majority of US healthcare, but there are situations where hospitals will get a per member per month fee to take care of patients, and then they're on the hook to pay for all of the care. So essentially the hospital is also the insurer. And in those cases, you really need to identify your high medical need patients and send extra care resources to make sure that they take their medications, they show up for their appointments, because otherwise they get really, really expensive. They end up in the emergency room and they end up with surgeries that could be avoided, things like this. So basically the software was being used with good intent to identify the neediest patients to give them extra care resources. Well, some informatics researchers at one of the Harvard hospitals in Boston heard about this software being used by their hospital, and they said, we'd like to study that. We're curious how accurate it is. And so they asked permission and at the hospital and said, can we play with the software? Can we run some validation studies? And they got permission. And they looked at some data patterns, and this was the most interesting data pattern that they found. I have to orient you to this diagram a little bit. This is from the journal Science. So it's a little bit of a weird graph because the x-axis is the dependent variable here. So the x-axis is the predicted cost of the patients, basically the predicted amount of medical expenses in the next year. The y-axis is the actual number of chronic conditions that the patients have. So you expect them to be correlated. But what's distinctive here is that the data segregates out into two lines. The purple line on the top are Black patients, and the orange line below are white patients. So why is it that Black patients and white patients would segregate out so cleanly and distinctly? And particularly with the pattern that if you were Black, you had to be twice as sick for the software to give you the same medical risk score as a white patient. Or in other words, two patients with the same amount of medical need, those care resources were going to go to the white patient because the software would predict them as being needier even though they weren't. You had to be twice as sick to get the same score. So where does this come from? Obviously, whoever wrote the algorithm is a blatant racist, Ku Klux Klan member. What's the answer?
My guess would be they used historic data.
Exactly.
Black people spend less money because they have less.
Because they have less access to the care. And this is a known fact. Health services researchers have known this forever. Black people in the US are more likely to live in communities with less structural access to the care resources. And so they tend to be undertreated on average versus white patients. And it apparently was going on in whatever historic data, real world data set they used to train the algorithm. So yes, this is the answer. So what went wrong here? So why was United Health selling an algorithm with such a blatant bias that they didn't even know about? They were selling this. They hadn't, the company had not studied this to discover this. These are some informatics researchers that discovered this. There's obviously a slip up. So not only did the company not study this on the, at the time they developed the algorithm, but they also notably were selling this to a bunch of hospitals to apply on local data sets without any validation going on there. Now, the departments at these hospitals that were using the software were not data science, were not big data science capable centers with PhDs. These were like either nursing departments or care management departments with social workers. They didn't have expertise to know how to validate this stuff. United Health had an obligation to help them understand where the software could go wrong and help them do the validation, and they didn't do it. And there was zero transparency. So when the news came out about this, people asked United Health, how many people have you sold this stuff to? And they were very evasive, and they finally admitted, well, it's more than 50 hospitals, but they never gave an absolute number. They never followed up to identify, what the harms were, who was harmed, how. They didn't want to know because they didn't want it in the news. They just covered it up as best they could. So United Health has been extremely quiet about this whole situation, although it's gotten a lot of coverage in the US. And it's gotten coverage as a racism problem, which it is, but in another sense, it's also a machine learning problem and an algorithm problem, because the bias could have been, on any variable in the system, not race, could have been on anything. And you've got people selling machine learning systems that are not properly validated and not locally validated. And again, we have no idea what the harms were, but people may have been harmed by this. So the impact of AI in our world is growing quite fast. And in the last few years, it's really started to come into the healthcare space more and more, but in a way that is relatively unregulated, and relatively not overseen, and industry has not sort of done its job to self-police. I also argue that, you think of all the fields where AI gets used. So marketing is at the top of the list historically. Google and Facebook are really leaders in AI because it's all marketing, it's all targeted advertising. So yeah, there's some ethical implications to targeted advertising, and I would argue it's really problematic, but healthcare is an even higher bar than that. So let's tie this back to medical ethics. So a bust of Hippocrates here. People outside of medicine think of Hippocratic Oath as sort of what the definition of medical ethics. People inside of healthcare know that the Hippocratic Oath is more of a historical document that reflects Greek values 2,500 years ago. Modern medical ethics has evolved and developed quite a bit past that. But the key principles here, pretty widely agreed upon. Respect for persons, which, basically autonomy, ability to decide for yourself. We're having an interesting discussion this morning that maybe this gets interpreted differently in the US than in Australia. But at least American ethicists would argue that patients should decide for themselves what care they're going to receive and control over their own bodies and their own data. Beneficence, everything we do in healthcare really should be with a legitimate intent of doing positive for patients, and non-maleficence of avoiding harm. And then justice is sort of taking that principle up to the population level, making sure we have fairness involved. So these axes are somewhat orthogonal to each other. You can't optimize one without impacting the other, but in a holistic way, these are basically the guiding principles that we need to follow. Along with that, I would argue that there's an important, it's important that we tie in scientific values and ethics into this picture as well, because this is where a lot of the accountability comes from. We can talk all we want about medical ethics, but if there's no accountability in place, then it doesn't get enforced. And a lot of the accountability really needs to come from the scientific community. These principles of publication, of openness, of transparency, of studying things before we use them. Without that, the other part doesn't fully happen. So I think these go hand in hand. So the two, taking this back to AI, if we really want to simplify it down, most of the harms end up falling in one of two really broad categories. There's sort of the privacy related issues and then the bias related issues. So I'll sort of talk about these separately. I'll send you the slides after. So privacy. So who here in the room, at least, I can't do a raise of hands outside the room, but knows about the Target case in the US? You know about this one? You do? Okay. So this was about 10 years ago, 8 years ago, maybe. Okay. So Target is a large retail store chain. And about a decade ago, senior executives at Target were looking at, this AI stuff that Google and Facebook were doing and saying, well, we need to use this too. And they basically assigned their IT people okay, so you go to the grocery store. Do you have those loyalty cards here? Okay, so you generate a lot of market basket data about what things get bought with other things to create patterns of personas of your customers, and you use it largely for targeted advertising. So they did this at Target to try to send ads and coupons to people based on what they expected them to be interested in, because that is more efficient than just sending the same coupons to everyone. And it's not that hard to come up with algorithms that actually work pretty well when you do this. And it turns out that one of the shopping patterns that's pretty easy to pick out of the data is for babies. So when you see customers in the data that are women between, say, 15 and 40 that are either buying vitamins or a size larger of clothes than they bought last year, or those kinds of things, it's a pretty easy signal to start sending them coupons for baby stuff. And so Target was doing this. And what happened was a 16-year-old girl in a very religiously conservative household living with her parents started getting coupons for baby supplies. And the father was livid. And he marched into the local Target, demanded to speak to the manager, said, how dare you send, baby formula and diaper coupons to my 16-year-old daughter? I don't want her thinking about getting pregnant. And of course, you can guess the answer is she actually was pregnant. The algorithm was correct. But is this a medical privacy violation? Absolutely. Pregnancy is a medical condition. Did this put the patient at risk? Absolutely. She's living in a family that, she may have adverse consequences by her parents finding out about something that she hasn't chosen to divulge yet. 16-year-old is in that sort of range where they start to have some autonomy, or they should. And they certainly need some protection. And Target had no business spying on her shopping patterns in order to cause this harm. But there is, in the US at least, there is zero law to govern this, because Target was not a hospital. Target is not subject to healthcare privacy laws because they're a store. And if they had stolen her medical records to do this, then there would have been a criminal problem. But they didn't steal her medical records. All they did was spy on her, and that was okay legally. So we have enormous quantities of personal data being used in this world, much more than 20 or 30 years ago, all for commercial purposes with very little oversight. I think the Europeans are starting to try to get a handle on this slowly. The Americans, I would say, are starting to think about it, but are behind the curve. And I have no idea where the Australians are on this whole data privacy issue, but I think the whole world's pretty early on. So on that note, a couple of years ago, some news articles came out about Google. Google's, again, one of the leaders in massive data and one of the leaders in AI capability. And a few years ago, Google identified that a big commercial opportunity was software for analyzing healthcare data. I mean, if I were a Google executive, I would have identified that. It's a huge opportunity. We need that, right? We need that in healthcare is Google level capabilities in analyzing health data. So that's good. And Google said, well, in order to get good at this, to develop our software, we need some material. We need some actual medical data to practice with. So they started going out and signing deals with large health systems. And the article was pointing out 3 very large systems. So the one on the left is a hospital chain, not for profit, religiously affiliated hospital chain called Ascension in the US. Had about 150 million patients. How many citizens in Australia?
27 million.
Million? Okay, so 5 times as many people in this database as live on this continent here. Ascension handed them all of these fully identified medical records under a contract that said Google had to behave well and not misuse them, but they didn't tell anyone about this. So Google's done a number of these deals, all of them confident, all of them they tried to keep confidential. A few of the arrangements turned out to be with government or university affiliated hospitals where the contracts were subject to public records laws. And so journalists were able to get hold of them. So the one that I've read was the contract that Google did with the University of California, San Francisco. And it's actually a good contract. It's only about 2 pages long, the data use agreement, and it binds Google to basically only use the data for predefined research purposes, to destroy the data when they're done, to not attempt to re-identify any patients, to not sell or reuse the data for anything. So it was actually a good agreement. But I'm really bothered by the fact that Google tried to keep it secret, because the public deserves to know what's going on. One of these, the one in the middle actually, was University of Chicago Health System. And this is the only one I'm aware of where there was actually a lawsuit filed by someone who lived in the area who said, this violates my privacy rights. But unfortunately, they couldn't pass the legal bar to get that lawsuit completed, if you will. The judge basically concluded that the patient didn't have enough standing or enough evidence of harm or something. But so it really hasn't been challenged legally in a big way, but Google's been doing this, and Google is almost certainly the single largest global controller, holder, user of identifiable medical data in the world. We don't think of that. We think of hospitals as being the repository of medical records. Google probably has more medical records than anyone in the world right now. And I hope they're not misusing them. Maybe they're not misusing them, but it still doesn't feel quite okay. So again, there's some positive things to how they've approached it. And there's no evidence that Google has misused the data, but doing it confidentially is not okay. So a couple words about existing privacy laws that are really inadequate. Again, the Europeans are trying to fix this, but they're not very far down the road. So one of the big ones in America is this de-identification loophole. So under US medical privacy law, if you strip out names, birth dates, medical record numbers, a few other fields, you can declare that that data set is anonymized. And you can do anything you want with it. You can sell that data, you can give it away, use it. It's right, exactly. You can treat it as if it were anonymized, even though it really isn't, but it's de-identified. And under US law, the way it's currently interpreted, and that's another debatable issue, whether it's being interpreted right, but the way it's currently interpreted by the US government, you can do anything you want. So there is a major industry in the United States, data brokering. Big companies purchase de-identified data from hospitals, integrate it together, link it all together in large databases, and sell it off mostly to pharmaceutical companies, largely for targeted advertising. So they know which doctors and market research, but other commercial uses, not medical research uses. Huge business, completely legal, and the public doesn't really know about it. So one problem with US privacy law is the identification loophole, and we'll talk about that in a minute, and I think you probably know where I'm going with this. The second problem is, well, I'll get to this in a minute too. It's okay. So first of all, de-identification. So the problem here obviously is that when a database is de-identified, but we're in the big data era where you've got multiple sources of data that you can link together, it's not that hard to re-identify data. So this was an article in Nature, basically doing the mathematics on how easy re-identification is if you have enough data. Now, a lot of the early research on this was from the medical informatics community and LaTanya Sweeney at Harvard. Does everyone know the Massachusetts governor story? You know this, don't you? The state of Massachusetts in America wanted to be really progressive. So at around the year 2000-ish, they decided to make the state medical insurance database. So basically, anyone who got their health insurance through state government, which was probably a couple million people, the state government made that data set available in de-identified form for any researchers who wanted to use it, because they thought this will jumpstart the software industry. It'll make us really advanced and technological. It's data sharing. This is a good thing. So LaTanya Sweeney, this young medical informatics researcher who was doing her PhD at the time, she said this isn't quite right. And to make her point, she took the publicly available data set, she cross-referenced it against the state driver's license data set, which was publicly available. And she wrote a newspaper article listing the governor's medical records because it was that easy to cross-identify. Now, how she did this, the one database had zip code in it. And so it had age, zip code, and sex. And the governor happened to, it was 50-something male and lived in a wealthy suburb. And it wasn't that hard to do the cross-referencing to find his medical records in this de-identified data set. But the bottom line is, all this de-identified data is immediately re-identified when the pharmaceutical companies or the data brokers or whoever re-identify it. So it's problematic. The other big problem is sort of—
What are the 15 demographic attributes?
Oh, this was a theoretical.
Okay.
This was a modeling study. So they were basically doing the math. But the thing is, if you think about the database available to, say, Facebook, Facebook has more than 15 attributes on every user of their system. And they're good at this. Okay, you've had this experience before. A couple of years ago, I had a family member that was having some leg swelling problems. So I did some Google searches on my laptop for venous insufficiency and support stocks to help out advise this family member. A few hours later, I pulled out my phone, different device, was looking on Facebook, different application. Guess what I was getting advertisements for? Support posts. The cross-referencing capability is incredibly well developed at these companies. And the identification doesn't work. It just doesn't work. Okay, the second problem is related to that. So Lawrence Lessig is a Harvard Law School professor, and he draws a really interesting analogy between privacy and copyright. So the link between these two things is that both of them changed completely in the digital world. Because the problem is in a digital world, everything's infinitely copyable. And so copyright becomes much more challenging. And we saw this mostly in the music industry, when you could very cheaply copy music and distribute it over the internet. And so the music industry had to pivot from a physical controls world to a asserting rights over digital copies world. And so his argument is we need to do the same thing in privacy. Most privacy law is based on preventing initial access. That doesn't work. We know the horse is out of the barn. Is that an Australian term too? It's too late. Our medical records are already out there in the world. Law to prevent them getting out in the world, it's too late for that. Where we need to focus our legal efforts on is penalizing misuse. And the other reason why this is important is different uses are not morally equal. And we see this in academic environments where doing positive pro-social research on medical records often requires these huge barriers to get past the ethics boards. And you know that Google and Facebook are not self-subjecting themselves to the same level of scrutiny. So there's a mismatch here. If you want to do good things, it's harder to do good things than it is to do bad things. So the whole framework needs to switch to that privacy law needs to be based not on getting access to something, but rather what you're doing with it and what the impact on patients is, and whether this is a pro-social thing or a marketing thing or an evil thing or somewhere in between. So anyway, okay, enough about privacy.
One short comment on
yes,
the
yes.
attributes. I mean, both the voter list and the data set that was released contained the date of birth, not only the age. So, I mean, that was very, very helpful for it accounts for nearly all of the re-identifications. Yeah, age can be very problematic. I mean, like exact age by day. The computer science world has done a lot of work on all of this stuff. How do you it's done a lot of work on privacy and the mathematics of how far do you have to de-identify things. But the legal world hasn't kept pace with that. And even synthetic data sets you have to be careful with. So privacy is a big, under addressed problem.
Brian,
Okay.
before you go on to bias, can I ask you kind of a hypothetical about this? Is there, from a patient perspective, is there really a difference between Google and the hospital having your data? So the spirit of HIPAA, which is the privacy law in the United States, is persons that are known to that there's a personal relationship with the patient, which would be the physician that I saw.
Yes.
But most people in a hospital setting, I have no personal relationship with. I have no personal relationship with the pathologist or the radiologist. But yet within that institution, generally as interpreted, anyone that's a physician in that system is basically treated as if at the same level of the person with a personal relationship. And is that any different than the hospital?
And the informatics community has done a lot of work over the past 30 years to facilitate that, to make data as shareable as possible. And I would argue on two grounds that you've got a good point. Number one, healthcare is much less personal than it used to be. It used to be your relationship, like you say, with the physician. Now it's this massive organization that you don't have the connection with. And then on a sort of moral and ethical grounds, the larger hospital systems get, at least in the United States, so I can't totally claim that this exists here, but it may. But in the United States, at least, the larger these organizations get, the more they act like for-profit corporations. And frankly, the actions of large hospital systems and their CEOs are really indistinguishable from for-profit organizations. Okay. And anyone that wants to book one time to talk about these, because I'm not going to make it through all my slides. Email me. Okay, so a few words about bias. So I'll cut this one short, but it's interesting if you want to sort of research this. So it turns out that this whole idea of racial bias in facial recognition is a real thing, and a lot of the work was done on this by these two researchers. It's not a coincidence that they're Black. They're both computer science researchers who were in Boston at the time. And the one on the left, Joy Walwini, I think she was working on her master's degree at MIT. And she just stumbled across the fact that Facebook didn't recognize her face very well. It usually misidentified her, and half the time it thought she was male. This was back when Facebook used to, if you put a photo of you and your friends, it would put the names on. Well, it turned out that it did a lot more accurately if you were a white male than if you were a woman of color. And Black males and white females are sort of in between. Why is this? We don't know exactly why this is, but I'll tell you, a likely theory is that if you look at Silicon Valley, you look at the makeup of who works in Silicon Valley, the vast majority of engineers in Silicon Valley are white males. And then the second largest group are South Asian males, but very few women and very few Black or Hispanic or other backgrounds. So probably whoever developed Facebook's image recognition software used a training data set that they didn't notice was overwhelmingly white male. Probably what happened. This kind of stuff happens. Here was one, if you've heard of this one, Epic, the medical records company that I hear is gaining some traction in Australia. So a few years ago, they wrote some software to predict sepsis, basically monitoring different data elements in the electronic health record to try to signal if a patient might be vulnerable to, or if the patient might have early sepsis, and then it flashes an alert to the doctors. And they initially did a good job with this. They studied it at some academic medical centers. They published peer-reviewed journal articles with academics to show how reliable it was. And then they started selling it. What they didn't do was validate this at each of the institutions they sold it to. And you know that health records are very different at different institutions in lots of subtle ways, and care processes are very different. And they didn't bother to really critique any of this. It was a very sloppily done algorithm. One example of how it was sloppily done, when they looked into it, someone discovered that one of the variables in this algorithm was whether antibiotics had been prescribed for that patient or not. It was circular reasoning. It was basically a badly done algorithm. And Epic was selling this, and the head of Epic, Judy Faulkner, would repeatedly chastise hospital executives, saying that they were killing their patients if they didn't purchase the software. And yet it didn't work. It didn't work. And there was a really a well-done paper in JAMA showing just how bad the software is. Now, Epic has come around and promised some reforms. They promised to do better, but yeah. So anyway, I'll skip the regulatory agency thing, except to say that at least in the US, the FDA has done an embarrassingly poor job of overseeing artificial intelligence. They really don't have the processes or the expertise or the structures in place. They've been approving a lot of stuff they shouldn't approve. To sort of wrap it up, what are some paths forward? Or for one thing, we really need to get away from this, need to see proprietary black boxes as a real problem. AI needs more study than other things because of the complexity of it. And so we really need to embrace that the AI is something that needs to be, have a particularly high level of oversight and monitoring and study. And the academic community, I think, has a really big role to play with this. So, roles for the informatics world. I think medical informatics has a sort of a logical, natural leadership role in speaking out and studying these issues. And at a service level, I think medical informatics departments have, I hope, an opportunity to take a large role in validation and study and critique And we need to insist that corporations that sell algorithms cooperate with that and sort of be forced to cooperate that by their customers. And there's huge research opportunities sort of studying the different ways the bias can occur, the different ways the harm can occur. So the good news is there's an enormous amount of academic opportunity in this whole area, and I hope that plays out well. So thank you for giving me the chance to come visit today, and I think we have time for more questions.
Oh, yes, thank you. We'll open it up. Are there any questions online today?
No, none yet, but.
Yes.
So when, as an academic, I meet with industry folk and they tell me they have software,
Yes.
what are the 3 things you would ask them to know whether it's BS or not? Because I think the first thing is, have you published on it? I feel that's a good, but would you say that's essential?